Hello students, welcome back to class. Welcome to week 15. This will be your last lecture. Before we get started on today's lecture, which will be over antidepressant medications and antipsychotic meds, let's talk about your homework assignment, which was actually performing the Widmark calculation. So let me share the screen. I'll go to just like a blank PowerPoint slide, and we'll see if I can just pull this slide up just so I can have a blank screen. So I should be sharing the screen here now. So basically what you had to do here, I gave you all the information. You know, there was a lot of information that you needed here that, you know, for example, the 1 fluid ounce goes to 1 fluid ounce. Let's see if this is going to work. Yeah. So 1 fluid ounce, and you know, my handwriting's terrible, is, you know, 29.57 milliliters. You know, average beta, they're, you know, anywhere between 0.10 and 0.025. Now the rho, we talked about in lecture, there can be the 0.68, and that's in liters per kilogram. Let's see. And that's for men. And remember, there's a lot of, there is a lot of, well, how should I say this? It can be contested in court what these parameters are, which in lies some of the problems doing the interpretation. So, so here is for women, the rho. So 0.68 liters per kilogram for men, 0.55 liters per kilogram for women. And remember, the rho is just Widmark's terminology for the volume and distribution of ethanol, of alcohol. Other stuff that's useful is to know that, you know, you multiply pounds by 0.45 to get kilograms, because you have to do the calculations in kilograms. The specific gravity of ethanol is 0.789 grams per milliliter. That's useful. Oh, and then the other one you actually need to do at one point is you have to convert to deciliters. So 1 liter to 10 deciliters is also kind of useful. So you have all that information. Now in practice, you know, if you get called up in court, you probably just want to have these terms, you want to have all this stuff memorized so you can just, you know, try to do the calculations. In your guys' example, now I don't have that slide in front of me. I don't know how I can pull it up at this moment, but I believe, but this would just be for any example, but I believe the question I put on your slide for the assignment was, you know, like 6 beers consumed. Oh, I don't know why it crosses out when I do that. So 6 beers consumed, 2 shots consumed. And, you know, the hard alcohol can be in different, you have to kind of know, like, if it's 80 proof or 100 proof alcohol, and I gave you that information for this assignment. So remember, for a beer, you're looking at probably about like 0.5 fluid ounces of pure ethanol per beer. For shots, that one shot is the same. If it's like 80 proof, it's 0.5 fluid ounces of ethanol. So your total amount of ethanol then for this consumption is 3 fluid ounces for the beer, 1 full fluid ounce for the spirits. So you're looking at 4 fluid ounces, okay, consumed. What am I doing? Jeez. It's kind of hard writing on the screen. So 4 fluid ounces total of pure alcohol consumed. Now, in the question I sort of posed to you, like, yes, if there's a window of drinking, you know, the way I like to think about it, and again, people can do this differently, but the way I like to think about it is like, you don't really know when the drinking took place during that window. Was it all at the front end? Was it all at the tail end? The only thing you know is when drinking stopped. You know when the person left the bar or whatever, right? So you know drinking stopped at this time, and then you know how much time has passed from that point on to when the testing has taken place. So those are your kind of like, that's the only time frame you really know. So I like to just go in there and say, look, the drinking stopped at, I think in this case 11. And then the test is taken at 1, so 2 hours is what you kind of have to build into your calculation as far as removal of alcohol from the system, and that's the whole beta term that you'll need to do. And like I said, people use 0.01, people use 0.010 sometimes, or 0.025 for beta. So it's a range that I'm trying to, I'm not saying you subtract these two, I'm just saying this is a range, right? This is a range that people use. Also, people use 0. Like the middle ground, like a 0.015 too. So since the question's giving you a BAC range, the way I think about this question is like, that's probably because they're using different betas. But that's kind of the way I think about it. So that's why I said go ahead and use these two betas and see if any of your answers are one of the answers that you have for you in this example. So now that we have the 4 fluid ounces, we need to do something right with that. So we'll multiply that by the specific gravity, or we'll actually multiply that by the fluid ounces to get it to milliliters. So 29.57 milliliters in 1 fluid ounce, right? Okay, and then, so then for that we have 118.28 milliliters of ethanol. Okay. All right, oops. Okay, then we multiply that, so hopefully you guys, and so what I'll be doing, going through grading your guys' work for that question is like, I'll just see if you're getting these numbers, right? I'm not gonna be a big stickler on like taking tons of points off for that, but I did want you to attack this and try to do that a problem on your own. A lot more, I think, interesting for you to just try to do it on your own. And then, I think the retention is a little bit better if you had to really figure it out in your head versus me explaining it to you how to do it right off the bat. I don't think it's as useful. So, all right, so let's finish up here. So we got 118, but 28 milliliters of pure ethanol. Then we subtract, or we multiply that by the specific gravity, all right, of ethanol, which was given. Okay, and that calculation drops off with 93.32 grams of ethanol, total grams of ethanol in this drinking session. Okay, oh, I keep doing that. Sorry. So that's their drinking session. Then you can kind of plug and chug, right? So we gave you the equation, right? The simple equation for Widmark is the C equals alcohol concentration, right, over W times R. So this is terrible looking. Sorry. It's the first time I've done extensive writing on the screen. So that's our equation. So we have the weight. So we have the alcohol concentration, okay. We have the amount of alcohol. We have the weight of the individual, and we have the row, okay. So now we had to just kind of plug that in to the equation. So for concentration then, I don't know why it does that. So for concentration, we'll have, so the 93.32 grams of ethanol over the 90 kilogram person, okay, for that example, times the row, in this case, it was a man, so 0.68 liters per kilogram. And then what you'll find is that hey, dang it. What you'll find is you'll get a number 1.525 grams per liter, okay? But what you want to make sure you do there then is get it to deciliters. So one liter, okay, 1 liter is 10 deciliters. In doing that, you should get 0.1525 grams per deciliter, okay? Now, another question that people are asking me is like the grams per deciliter. That is equivalent to percent BAC. So BAC the implication of BAC, percent BAC, is grams per deciliter. So those are kind of like equivocal units. So then all you needed to do then was take this and subtract 2 hours of row, right? So if you're going to use, so you know, here's your number, right? You would, so for the, if you're going to use this first row, right, 0.01, you know, basically you're going to go 0.010 times 2 hours is 0.02. Pretty simple. You would subtract that from this number here, right? And then you would do it again for the 0.025 and subtract that number, and then you would have a range that would be rough, you know, basically 0.10 to 0.13. Okay, and that's going to put you in that range. And I believe I don't have it up anywhere. I guess that was. Let me see if I can pull it. That was last lecture, or that was the drinking study lecture. Let's see here. Not the drinking study lecture, but the alcohol. Which lecture was that? Let's see here. Nope. Maybe it was this one. It had the videos in it. All right, yeah, so this is from lecture 15. So I do want you to be familiar with this equation, and I've not now gone over it for you guys. So if it pops up on the on the final rather, that would be something for you to be considering. Some variation of the equation. You got to make sure you have some of these conversions and units memorized, right? So for the question, the closest one is C, right? So 0.10 to 0.12 is basically what we've gotten here. So that would be, the answer is C. And in fact, the answer is C. Okay, so this is, so what you guys have in this slide for this equation is a actual certification exam question for ABFT. The American Board of Forensic Toxicologists has a certification process to become board certified. And every single one of you guys, if you guys get into the career, you guys get into the forensic sciences, we're seeing a big push to get everyone certified, and you know, to get board certified in your field. So these kind of questions might come up. All right, so there's the alcohol-Widmark equation, hopefully. And I did glance at a couple of your guys's, because some of you had emailed me questions about it. It looked like some of you got off on some tangents, and but some of it looks like some of you got the right answers, and so it's all good. There's no wrong answers here. You know, I'll probably give you full points for most of this assignment. Just wanted you to give it a shot, and remember that, you know, Eric P. excuse me, Eric P. Widmark is this guy that basically found out the pharmacology and the pharmacokinetic parameters, named him his own, right? So rho and beta, to describe volume and distribution and elimination of ethanol. So kind of important. Okay. So with that, let's move on to the lecture for today, and that is antidepressants and antipsychotic medications. So antidepressant drugs, this is kind of like a joke first slide, right? Side effects may include suicidal thoughts. The interesting thing about some of these medications is that they do have side effects in some individuals. Some of them can be pretty severe. And some of the side effects that do include suicidal thoughts, which is actually a thing, it can be related to some of the effects of the withdrawals of some of these drugs. So some of these drugs can have sort of severe withdrawal effects. So that means once you got on a dose of some of these medications, then you do need to titrate yourself off. Okay, you don't want to just stop cold turkey, and that's because some of these drugs can have some awful side effects, even though they're trying to help the underlying depression or the you know, prevent psychotic episodes. So just keep that in mind. And now you might be wondering, what does this have to do with forensic science? Why do I care? Well, a lot of people are on these medications. Some of the most highly prescribed in the world, which is interestingly, you know, so what happens then is in forensic toxicology, people do end up killing themselves. Some of these drugs do have side effects that might change someone's behavior. And in particularly in postmortem toxicology, you can find a huge amount of this on board. And so the forensic pathologist will often want to know if, maybe this is maybe if the case was a overdose scenario. So they'll want to know how much of the compound is on board, and they'll want to get quantification levels. So they end up being drugs that you're going to really need to know about in a forensic toxicology setting, in particularly a forensic post-mortem toxicology. Okay, this slide's for you guys. Graduate school can have a terrible effect on people's mental health. Hey, you know what? So much anxiety, so much depression all over the country, all over the world because of the pandemic and people cooped up. And I mean, so I really feel for you guys. You guys have all that on your shoulders, plus graduate school, which by itself ends up becoming pretty challenging and a big burden. But you're not alone. I mean, when I went through graduate school myself, getting my PhD was, I went all the way into the gutter at one point, but I had to you had to like build yourself back up and come on out of there and finish strong. So it can be trying, absolutely. But that's kind of the reason why we have some of these medications is to deal with anxiety and depression. So when I saw this in the Atlantic article, I just thought I'd tack it on for you guys. All right, so the antidepressants, the DSM-5, and we've talked about the DSM-5 manual, which is a big manual that allows people, that allows everyone to have a classification of a condition, with the idea of having that classified. Then you can actually create a drug to treat that classification. And so some people think the DSM-5 is hilarious because it's sort of like, used to be a book this thick and now it's a book this thick. And the people sort of pushing to classify conditions are sometimes like drug manufacturers themselves that just want to create a drug for that thing, right? And so, that's not always the case, but sometimes I think that can occur in this world of pharmaceuticals. So anyway, the DSM-5 defines adjustment disorder, the presence of emotional or behavioral symptoms in response to identifiable stressors. So a lot of different things can fall into the realm of when a drug like an antidepressant might be prescribed. Now, basically, what these can be prescribed for many things. So, bipolar disorders, mood disorders, schizoaffective disorders. There's a whole kind of, rainbow of different schizoaffective disorders. So people that can sometimes see things, anxiety, OCD, panic attacks, PTSD, so many. So there's quite a bit of ailments where, again, you can see where these drugs can sort of fit in. They can be on board. They can show up in people's toxicology, which is basically, what we're interested in here. So anyway, let's move on. So, okay. Sorry, I'm getting all these emails. Okay, sorry about that. All right, so got a lot of stuff going on right here. My apologies. All right, so let's move on. So a key point here, which is really interesting. I was just talking to my wife about this last night because my wife is actually a physician, so she works as family medicine. So she prescribes a lot. She'll end up, suggesting medications for individuals, and anxiety and depression are things that are she sees often, and even more so in these sort of challenging times that we're living in. So, but one thing that's really interesting about this class of drug is that there's typically like this 3 to 6 week delay before there's a therapeutic effect, and that's really interesting, right? And challenging, because it's like you're taking a medication for like 2 weeks and you're still depressed. So why am I doing this? So compliance is an issue, right? So drug compliance is a term that we're talking about. Are you taking your medications when you're supposed to? And so, so this is kind of problematic for this class of drugs, and it's sort of an enigma. But I'll talk about later in the lecture some of the hypotheses that we have of like why antidepressants take so long to actually work. So we can get into that. A lot of different antidepressant drugs to talk about today. The tricyclics, some of the early ones, MAOIs, so the monoamine oxidase inhibitors. There's the serotonin selective reuptake inhibitors. And then there's also the serotonin and norepinephrine reuptake inhibitors. And then there's just newer ones. Anyway, new news. um, yeah, I don't know what's going on there. Sorry about that. And then we'll talk about novel antidepressants. I'm getting real-time emails about information that might be kind of important for you guys. So sorry about that. It's like about classes and basically how things are going to shake down for our spring. I actually, as I'm recording this today, I actually got a flash, like the the emergency Amber Alert thing where like your cell phone starts beeping if something, my phone just beeped that, and it was from Orange County, and it's like COVID-19 spiking, stay inside, don't go anywhere, new orders. Oof. That was surprising to say the least. Talk about anxiety and depression, right? So all right. Let's get into the first class. We'll talk about the tricyclics, you guys. So first generation drugs, very effective, okay? However, issues with it being lethal in an overdose situation. The lethality of the tricyclics relating to irregular heartbeats, prolonging the QT interval, which is a pattern of heart rhythm, and creating a prolonged QT, which is irregular and can actually cause some pretty bad side effects and death. So some of those tertiary tricyclics were imipramine, amitriptyline, doxepin, for example. Now, this lecture is going to be heavy on lots of different drugs, you guys. So I want you not to memorize every single drug, but I want you to tell me what a tricyclic. Give me an example of a tricyclic. Give me an example of an SSRI. So let's just say I want you to know at least one drug from each class and know a little bit about the mechanism of these drugs, okay? But I'm going to go into a lot, and I want you to just know right off the bat that I'm not going to hold you to knowing every single one of these drugs, okay? But just kind of keep in mind that I do expect you to know a little bit about each one of these classes of drug, and then also maybe like one example of each drug. Okay, so tertiary tricyclics. So amitriptyline being a pretty popular one as an example. So they do lots of stuff. They have antihistaminic action, which has the side effect of sedation and weight gain. And weight gain is one we're going to keep hearing over and over again. So that's kind of a bummer. It won't happen in everyone. So some of these drugs are very useful and can treat people's depression. But in some individuals, we do see side effects, and you'll see the side effects profiles changing as we get into newer and newer medications, and that's the whole goal, is to sort of reduce these side effects. So the tertiary tricyclics also have anticholinergic effects. So you get the dry mouth, memory deficits, also anti-adrenergic, which we have sexual dysfunction is not being another major thing here. So so you're all depressed and bummed out, you're taking the antidepressants, and your sort of sex drive goes away. This can be a huge problem for someone, right? And so that's another issue. So they do act predominantly to block the reuptake of serotonin. Remember, serotonin is designated as 5-HT to produce some of their effects, and also some norepinephrine reuptake as well. Okay, here's an image that looks like it was taken right out of the textbook I did. I thought you guys should buy. I don't know if I made you buy it, but it's the Forensic Toxicology by Barry Levine. Really great book if you haven't picked it up. But anyway, in the chapter here, what we'll see is, in general, all antidepressants are extensively metabolized by cytochrome P450 enzymes, and they're either demethylated or hydroxylated. And many of the actual metabolites are, so you see like amitriptyline goes to nortriptyline, then 10-hydroxynortriptyline, right? So you'll see that some of these, nortriptyline is a drug that you can buy by itself, amitriptyline also. So the metabolites in themselves can be psychoactive as well. And we have the secondary tricyclic, so dizepamine and nortriptyline, right? So that's the metabolite, right? So they're often metabolites of the tertiary amines, okay? Primarily to block the reuptake of norepinephrine with some serotonin activity. Side effects are generally the same, but sometimes less than the class we just described. So better use profile there. All right, let's talk about the monoamines oxidase inhibitors. Okay, so Marsalid, ipronazide is one major one, and there's others. Okay, these bind irreversibly to monoamine oxidase, thereby preventing the inactivation of, the amines like norepinephrine, dopamine, serotonin, leading to increased levels of those. So remember, monoamine oxidase sort of breaks down the transmitter after it's been released in the synapse, comes back in, it can get broken down. This compound actually blocks the breakdown, so you end up having more of it around. These can be very effective for depression. However, the side effects, again, we see weight gain, we can see sexual dysfunction, sleep disturbances, hypertension, which is can be bad. So, you can get like blood pressure issues with these medications, so that has to be monitored. So again, lots of interesting things. Also with MAOIs, tyramine-rich foods, like aged cheeses can like affect the, can be an issue, which is kind of an interesting thing. So some of the foods that you eat need to be taken into consideration when taking MAOIs. Now, another thing that can occur with like a lot of these medications is what's known as a serotonin syndrome. And so I wouldn't be a good professor of pharmacology without, talking to you for a minute about serotonin syndrome. So this can develop if taking MAOIs or any other combination of medications that increase serotonin levels. Now, serotonin syndrome can basically be just like too much of it on board, or too much of it in the central nervous system, and this can include side effects of abdominal pain, diarrhea, sweats, tachycardia. You can get monoclonus, irritability, delirium, and it can lead to cardiovascular shock and death. Now, it's important to realize this because, if you are working on a case, and the prosecution's trying to prosecute somebody who looks like they were on a bunch of medications, or, or maybe they were, impaired to drive or something like this, and then you get the toxicology report back and they're just on some antidepressants, how do you explain that behavior? Well, one explanation could be serotonin syndrome. And so, that might be something to take in consideration. This person maybe wasn't abusing anything, wasn't trying to have this kind of behavior. But if they're suffering from serotonin syndrome just because of maybe some of the antidepressant medications that they're on, then that can be, an issue and potentially something that could explain someone's behavior. Okay, so that's why it's important to sort of know about that. So in order to prevent serotonin syndrome, you want to wait a couple weeks before you're switching between one drug and the next, right? So if you do have more of these drugs on board that are doing the same thing, then you can sort of, get to a point where you might get into serotonin syndrome. Okay, so serotonin receptors. So I remember I had this slide the other day, ending it off, but remember the solid lines are agonist action and the broken arrow lines are antagonist or inhibitor actions. And what you'll see here is the MAOI antidepressants, right, block MAO activity. And we just described that, okay? The tricyclics and the SSRIs, antidepressants, they basically block the reuptake of serotonin getting into back into the synapse, in the presynaptic synapse. So then they are hanging around longer. So that's sort of the mechanism of those drugs. So it's important to sort of know what the mechanism is of the drugs as well. Okay, so the serotonin selective reuptake inhibitors, or SSRIs. So as I just described here, SSRI is blocking serotonin from reuptake. So we have the blocking of that, and these drugs can treat both depression and anxiety. Most common side effects with some of these drugs is GI issues. The sexual dysfunction is a big one, but also you can get some, anxiety, which is kind of like what you're, might be prescribing it for. So that's sort of paradoxical, but you might get some nervousness, insomnia, fatigue. Some of the drugs also give you, or kind of make you sleepy and have some sedation. So, but the one thing that's great about the SSRIs is, even in an overdose situation, there doesn't seem to be the cardiotoxicity that, when we talked about in the tricyclics. That was a big deal, prolonging the QT interval, messing with heart rhythms. You don't typically see that with the SSRIs, so they have a better safety profile here. With the SSRIs, you can develop a discontinuation syndrome. Basically, you can get your body will adapt to these medications, and so you will have withdrawals from them. Okay, and Paxil is a good example of that. You do get sort of to a point where you can have withdrawals, so you become sort of almost physically dependent on it. So it's not like you're addicted to it. You're not taking it because it's giving you a great effect and you want to take it over and over again with a detriment to yourself. But you can be sort of to a point where you do have so much of it on board for so long that your body's so used to it, so you have this physical dependency that once you remove it, you can have some side effects, right? So, so the pros of like this kind of a compound has a short half-life with no active metabolite, but it does have sedating properties, which you may or may not need, but some of the cons of the compound is that it does seem to inhibit CYP2D6, and you guys remember from the cytochrome P450 lectures, if you're on any other drug that needs CYP2D6, then you potentially have some drug-drug interactions there. Weight gain is another big one with paroxetine. So, and again, like I mentioned, can have some withdrawal effects. All right. Another in the class is Zoloft. And so some of these are funny, you guys, because you might have seen commercials for these. So remember, the United States being one of very few countries in the entire world that allows the pharmaceutical companies to have commercials for drugs. Most don't let you do that. So, so Zoloft or sertraline has very weak P450 interactions, so only slightly inhibits CYP2D6, short half-life, less sedating than paroxetine. So there's more GI issues with this drug, but overall it's a pretty good safety profile, side effect profile. So that one's used a lot. You may have heard of Prozac, another blockbuster drug. Long half-life with this one. It's initially activating, so might provide some energy when it's taken initially. SSRI discontinuation syndrome. Secondary to long half-life can give one 20 milligram tab to taper someone off of SSRI when trying to prevent SSRI discontinuation syndrome. And so that has to do with its long half-life. So that might be a benefit of the long half-life, but a con of the long half-life is that some of the active metabolites that this drug have can build up. So if you have somebody that has hepatic issues, then this might not be a good drug for them. There are some significant P450 interactions. So CYP2D6 and 2C9 can be at issue with this drug. So as you can see, with all the medications we've discussed so far, it's sort of a hit or miss. You got to kind of consider the pros and cons. And remember, these aren't going to happen in every individual. Some of these medications may really assist someone feeling better, having better mood, snapping them out of their depression. And not everyone are going to get these side effects like the weight gain and stuff, right? You just have to sort of find out and figure out what medication is going to work best for you. So the SSRI discontinuation syndrome, so again, occurs like we mentioned before, kind of like serotonin syndrome, where you have too much of it on board. Basically, and we describe serotonin syndrome. The other syndrome that we're kind of describing here is basically when you stop these drugs cold turkey, you do get withdrawal effects, and so that's basically what SSRI discontinuation syndrome means. It's the side effect, it's the withdrawal effects of basically being sort of physically dependent on the medication for taking it for so long. So you just have to make sure you taper off, right? So this can occur in 20% of patients after an abrupt after an abrupt discontinuation. And you get the flu-like, insomnia, nausea, sensory disturbances. I mean, people can really like be in a world of hurt. Okay. Now, another class, the serotonin and norepinephrine reuptake inhibitors. Um, these are called SNRIs, and they inhibit both, like I mentioned, both serotonin and norepinephrine reuptake. But they don't have the antihistamine and antiadrenergic or anticholinergic effects. So these can be used to treat depression and anxiety, and in some cases, even neuropathic pain. And so these end up being even better as far as their profile. So venlafaxine or Effexor is a good example of that. Here's the structure here. Minimal drug interactions, almost no P450 activity, short half-life, fast clearance, so that's really good. Can have some issues with discontinuation syndrome, so you got to taper off of this one. You don't want to stop this one cold turkey. Can cause QT prolongation, which still has a little bit of the heart issues, and some of the also sexual side effects can happen as well. So that's one in the class of SNRIs. We have duloxetine or Cymbalta, and again, you might have seen a commercial about Cymbalta. Maybe we all have, right? You know, what's funny is like my family and I now watch basically Netflix, Hulu. So we don't have commercials anymore. We're basically watching those streaming services all the time. But when I do switch over to like live TV to like watch a football game or something like that, you get the commercials and it's always full of like pharmaceutical ads. You're like, oh, there they are. They're still out there. Lots of pharmaceutical commercials, right? Okay, so basically, blood pressure increase far less compared to venlafaxine with Cymbalta, so effect on blood pressure is better. There is some CYP2D6 and CYP1A2 inhibition, which is, again, got to be careful there. So another one, here's some novel ones. So mirtazapine or Remeron, this one has a different mechanism of action. It's a 5-HT2 and 5-HT3 receptor antagonist. So different, so it's hitting a different subclass of these receptors, and so might be useful. But a big side effect on this one is that it increases cholesterol in some patients by 20%. And triglycerides. So someone that already has high triglycerides or cholesterol, this might be an issue for them. And you also get the weight gain. So again, may not be a drug for everyone, but it does have a sort of novel mechanism, so that might be useful. We also got drugs like bupropion, which is Wellbutrin, and this is this is an interesting one. It has the mechanism of action that we think is most likely reuptake inhibition of dopamine and norepinephrine. We don't see any weight gain. There's no sexual side effects. So pretty good one. Some of the cons that it might increase seizure risk in those that are, have seizure susceptibility. So you want to avoid this medication with people with traumatic brain injuries or other factors or health concerns that might, make them more susceptible to seizure. Doesn't really treat anxiety like some of the other antidepressants do, but it's pretty good at the antidepressant effects. It also has some abuse potential, which is kind of interesting. Some people call it the poor man's cocaine. You can actually crush it and cook it. You can inject it on the street. People have been injecting this stuff, and when you do that, you get these abscesses, which is from all the binders and the inside these pills that people will crush up and boil and inject. So can have abuse potential here, which is an issue with it being on the streets. So summary of the pharmacokinetic data for antidepressants. So looking at the half-lives, you can see a wide variety of half-lives for all the medications that are out there, and these aren't all of them, of course, but this is what's in your textbook. We get some volume and distribution information, active metabolites, and therapeutic ranges, which is useful. And remember, for your presentations, that which again, the submission link is there now. If you do have a drug, I do want you to sort of describe some of these parameters, just in the context of the drug and its class, perhaps, or other drugs as well. So yeah. So why do these drugs take so long to work? Well, it's interesting to note that these drugs have similar mechanism to psychotic drugs that we'll talk about next, and hallucinogenic drugs. Yet those compounds do not appear to have any efficacy treating depression, at least yet. And so that's the key thing. So maybe the antidepressant class compounds exert their beneficial effects in other ways, which could explain why it takes so long for them to be effective. So the etiology of depression is still largely unknown. Like, we don't understand why someone gets depressed and what the actual neuronal specific mechanism is, right? And so we know some things, right? We know that release of endorphins from exercise have been shown to be as effective. So if you get on your Peloton or your workout bike, or go run around the block and exercise has been shown to be as effective as some of these drugs, okay, or better. And so we know that stimulating the brain in different ways can be very beneficial for treating something like depression. Newer research that's been really quite fascinating has been sort of low dose NMDA agonists have appeared to be really helpful for treating major depression. So a drug like ketamine, which is not at all used for depression currently, at least, they have been showing some interesting research of that really working well for treating really bad forms of depression. And it's like interesting. It's like a one large dose of the drug can actually have a lasting effect on someone's depression. So what is up with that? It's pretty interesting. So there's actually a lot of active research going in on this, and some of the actually Schedule 1 drugs like LSD and some of these other meds, and low dose, like micro dosing of those, seem to help as well. So we're still trying to figure it out. Another hypothesis that is kind of interesting of how these the antidepressants, of what they're doing, is that they're increasing the number of neurons. So we're creating new neurons, and that's a phenomenon known as neurogenesis. So for your biology students out there, you might remember learning about neurogenesis and how it occurs in development of the brain. There are regions that are neurogenic, so the hippocampus is one of them. So it does take time for newly born neurons to sort of turn on and incorporate and assimilate themselves into the network. And maybe it's what these drugs are doing, is creating some synaptogenesis, creating neurogenesis. And so those are some other sort of competing hypotheses of why these medications take a while to work, and how potentially they're benefiting overall. So let's get into another class of drugs. So we'll switch gears here and start talking about the antipsychotics and antischizophrenics, also a class called neuroleptic drugs. So the indications for these are schizophrenia, schizoaffective disorders, bipolar, delirium, other forms of depression like psychotic depression, dementia. And so it's a whole class of drugs. And so before we had the drugs, we did a pretty terrible job, and you could argue we still do a pretty terrible job treating people with mental health issues. This is an image from Bedlam, which is a famous first mental hospital that was going on in London, England, from 1677 to 1815. And this is basically where they sent all the crazy people, right, quote unquote. Terrible term, but they didn't really understand why some people might be suffering from these conditions. And we've seen these conditions in humanity for quite some time, like schizophrenia. And so people didn't really quite understand. They thought there might be demons in them. And so we have like this terrible history of trying to treat these. So here's an early therapy for you. Spinning the patient in a box until they lose consciousness was thought to help people by jostling the contents of their brain around, like sloshing their brain around. Maybe that'll like snap them out of the weird mental health that they have, right? So terrible. Straight jackets, the tranquilizing chairs, really pretty terrible methodologies. And again, just because it didn't really understand what's happening in the brain. So schizophrenia, it's a chronic and severe disabling brain disorder. And for all of these compounds, or I'm sorry, for all the drugs that are used to treat something like schizophrenia, they talk about the positive symptoms of schizophrenia, treating the positive symptoms, and treating the negative symptoms. So the positive symptoms of like something like schizophrenia are those hallucinations. So they're the delusions, the thought disorder, the thought and movement disorders, seeing things, right? Like being convinced that there's somebody in the room that's not there, right? Um, and you guys may have seen movies about people with, some famous people back in the day that had schizophrenia, or these can be scary. They can be debilitating. Some people can learn to live with it, but those are sort of the positive symptoms that most people want to not have anymore. And then there's the negative symptoms, which are a person can have this diminished emotional expression, anhedonia, which is lack of pleasure, lack of drive, reduced speech. So people just sort of shutting down. Now, what I'll tell you is that most of the drugs that treat schizophrenia, most of the drugs that we'll talk about today really only treat the positive symptoms. So we can basically treat the hallucinations, but you still may have these negative symptoms. So are they the cure for diseases like this? Basically, no. So the prevalence of schizophrenia in particular, it's like the fourth leading cause of disability in the developed world, which is kind of crazy. Lifetime prevalence varies from 0.5% to 1.5%. The incidence is actually a little bit higher in men. So men are more likely to have schizophrenia than women. And the negative symptoms tend to predominate in men, okay? And the depressive and also the hallucinations tend to predominate in women, and we don't know why. It's really interesting. So there is what's known as the dopamine theory of schizophrenia. I want to bring that up. So in normal folks, drugs that increase, so here we go. So in normal folks, right, drugs that increase dopaminergic neurotransmission can cause the psychotic behavior. So we have drugs like L-DOPA, dopamine agonists, and amphetamine type drugs. These compounds in normal people can produce some psychotic episodes, right? So in schizophrenic patients, right, increasing dopaminergic transmission exacerbates the positive symptoms. So you make their conditions worse if you do the same thing and put those type of medications on board. So the theory then is dopamine is related to this. So drugs that block the D2 dopamine receptor seem to help and assist at reducing the positive symptoms. So all the current drugs that we have that we'll talk about, they all do that. So all current drugs with antipsychotic activity block the D2 dopamine receptor, okay? And it's related to what I just described. All right, so what we'll learn first are that we have the first generation antipsychotics, okay? And they call these, for whatever reason, the typicals. So the typical antipsychotics are the first generation. The atypical antipsychotics are like later generations, okay? So we got first generation antipsychotics, the typicals. We have they're all D2 dopamine receptor antagonists, right? So we have the high potency typical antipsychotics. Again, they bind with the D2 receptor with high affinity. As a result, they have higher risk of what's known as extrapyramidal side effects, okay? And so some examples of this are haloperidol is probably the biggest one. Uh, Hold on one second, you guys. Hey guys, sorry about that. So what happens in my neighborhood at this time of the day is the street sweeper. And you got to be careful because the street sweeper comes and then you get a big ticket. So had to run out and handle that. Sorry about that. Okay, and then I think I've advanced the slides a little bit too much here. So let's go back. Okay, so couple drugs here in the typicals, okay, and I'll talk about the extrapyramidal side effects. That can be a big side effect of these compounds, okay. All right, so first drug here, this flufenazine, it's rapidly hydrolyzed in the blood. Its action of onset is here, half-life pretty long, 7 to 10 days. It undergoes extensive first pass metabolism, and it's metabolized primarily by CYP2D6 and CYP2D6. Oh yeah, that's right. This is a weird drug. It inhibits. Okay, it's metabolized by CYP2D6 and it inhibits CYP2D6. So this is the thing. It actually can inhibit its own metabolism. So go figure on that, right? And then you get haloperidol, which is a little bit better. CYP3A4 appears to be the major metabolizing enzyme, which you guys remember CYP3A4 being the big part of the pie, which is good. Another long half-life drug as well. So low potency typical antipsychotics, they have less affinity for the D2. So those are like the high potency. These are the low potency typical antipsychotics here in this slide. They have less affinity for the D2 receptors, but tend to interact with but they tend to interact with the non-dopaminergic receptors, resulting in more cardiotoxic and anticholinergic side effects. So you got thorazine and thioridazine for these compounds. So thorazine, considerable first pass metabolism, volume of distribution and half-life is here. 12 different metabolites. You get a lot of different metabolites and excreted in the urine. So this is kind of an interesting thing. So when some of these compounds came out, so John F. Kennedy had this really interesting vision for mental health. One of the last pieces of legislation signed before his assassination, so I'm talking about John F. Kennedy, the president of the United States at the time, in this time frame when some of these drugs are coming out. He passed the Community Mental Health Act, okay, aimed to build mental health centers that are accessible to all Americans rather than keeping people that have mental health issues in these neglectful state-ran institutions or hospitals. So what we would used to do is we take people with mental health issues and we put them into these hospitals, right? These mental health hospitals. And there's like some famous movies like One Flew Over the Cuckoo's Nest. Some of you guys have ever seen that, to sort of depict the bad conditions for the patients in these sort of facilities. So we were thinking, the thought around the time of Kennedy here is like, this is bad that we're doing this to people. Let's do better, right? So the Community Mental Health Act was aimed at doing that. And it coincides with the time of thorazine coming out, which was, in the views of like Kennedy, they thought this was like kind of like the cure for schizophrenia because it did such a great job at basically treating the psychotic episodes, right? But remember, really only treating the A symptoms and not really the B symptoms, okay, for schizophrenia. So, but out there with the legislators and all, the thirazine was, thought to be like the cure, and so, thinking that this was a cure, we have medications that are treating it. They thought that they would do this, but what ended up happening, of course, is that right after this time frame, we had like the Vietnam War, and a lot of money sort of diverted away for the Vietnam War, and so really this fell flat. And ever since, we've just done a really bad job at mental health treatment and options, so that a huge amount of the mental health burden is laid on the criminal justice system, right? So police officers having to get calls and interact with individuals, which really don't need to be interacting with a police officer. They should probably be interacting with a mental health expert, right? So there's definitely some issues with our mental health system currently as it stands. It's kind of an interesting history lesson there. So thioridazine, another one as well in the class. Again, so these are some of the earlier medications that can produce pretty severe EPS, or extrapyramidal syndrome. So these are major side effects of the drug. They can create these sort of like Parkinsonian syndromes of rigidity, tremor, postural abnormalities. You get acute dystonic reactions like facial grimacing, torticollis, and ocular crisis. Are also tardive dyskinesias, which has a late onset from months to years. And that's like the tardive dyskinesias are like lip smacking and sucking, chewing motions, and tongue protrusions, so your tongue sticking out. So that's kind of an issue. The torticollis is the kinked neck, and it's sort of that stuck kinked neck. And the ocular gehrinic crisis is the eyes, like in this image down here, being stuck, like facing up. So these are some huge issues that can be major side effects of the class of drug. Okay. So how this all is played out, we're talking about the central nervous system, and so to produce movements in general, right? So movement disorders, we're talking about different pathways, dopamine pathways. So the nigrostriatal pathway also is a factor here on the EPS side effects. So I just kind of wanted to also mention that diphenhydramine, which has really good anticholinergic action, is really good at treating the EPS. Can reduce EPS, which is a major side effect. And so that's also used in the front line when treating someone who might be suffering from these some of these mental health issues, especially in the emergency room. So remember, there's multiple pathways of different transmitters, and I think I have a slide coming up where we'll sort of talk about how some of these drugs have changed, and in doing so, become a better profile, better safety profile, and it has to do with the mechanism of action, okay, of the drugs. So in general, the autonomic nervous system, right? I mean, the pharmacological effects of these drugs, will block other types of receptors, blurred vision, dry mouth, also sexual drive. These are issues that we saw in the antidepressants. There can be some issues with the antipsychotic medications with hypotension and different heart rhythms as well. So a summary of some of these first generation drugs is that, they're not a cure for schizophrenia, but they can reduce some of the positive symptoms. They're considered dirty drugs, meaning that they can affect many neurotransmitter symptoms, producing many effects, many side effects. And like the antidepressants, it's unclear why some of the clinical effects take so much time to develop. So just like these drugs, it does take time for these drugs to become effective. Okay, so we have those first class, and then now we at first generation, now we have the second generation antipsychotics. All right, so these are called atypical. So we got the atypical antipsychotics, and these agents are not, so remember, all of them are going to block dopamine, but these ones have another little added bonus. They are 5-HT2A serotonin receptor inhibitors. Now we'll get into the mechanism of this, you guys, but it's pretty interesting, okay, how this ends up working. So they are considered atypical in the way they affect dopamine and serotonin. That's why they're called atypical. Most atypical drugs have a peak concentration of 1 to 5 hours after an oral dose. And again, they can be, analysis techniques, they can be identified in these drug screens, no problem. So, like I said, all antipsychotic medications have the D2 dopamine receptor activity, but this one has the uniqueness of the 5-HT2A. Okay, so let's get into this a little bit. Like I mentioned before, there are multiple dopaminergic pathways in the brain, all right? And so we have, in the nigrostriatal pathway is one pathway where we do see deficits, especially when somebody has a condition like Parkinson's disease. So we see those neurons in the nigrostriatal pathway start to go away and die. The results of which is, movement disorders. If you've seen someone with like Parkinson's disease, they start to, have like these, repetitive emotions, repetitive movement disorders. In other areas, there's others. So the mesocortical pathway, for schizophrenia at least, we see a sort of hypoactive. Uh, this can be responsible for some of the negative symptoms, and then the positive symptoms of like schizophrenia seem to result from the mesolimbic pathway. So these are specific dopamine-related pathways that sort of innervate different brain structures in the brain that we know about. So what ends up happening, which is kind of interesting for this class of drug, is that in the nigrostriatal pathway, and remember, the extrapyramidal side effects end up being this issue that looks very similar to someone who has Parkinson's disease. It's the grimacing, it's the postural abnormalities that we talked about, the EPS symptoms, right? The EPS side effects. So what we see is that in the nigrostriatal pathway, the 5-HT2A antagonism increases dopamine release, okay? And this counteracts the dopamine receptor blockade, okay? So remember, in Parkinson's disease, when dopamine neurons go away, and we don't know why, you have these Parkinsonian symptoms, okay? Like the grimacing, the EPS side effects, right? The EPS sort of like behavior, right? And so that's that disease state. Now, what we're saying here is these drugs that treat schizophrenia block dopamine receptors in this pathway, and in doing so in this pathway, you get the EPS side effects, which is bad, right? So we don't want those side effects, but we want D2, we do want D2 dopamine inhibition in those other pathways in the slide previous, right? Because doing so in those pathways helps out with the positive symptoms of schizophrenia and somewhat the negative symptoms. But it's this specific pathway, the nigrostriatal pathway, which is really quite clever what they've done here. So what they've done here is they've shown that you basically have autoreceptors. We have autoreceptors on the presynaptic neuron, okay? Those autoreceptors end up being hugely important, okay? Because what I'll tell you is that, check this out. Remember what autoreceptors do. So serotonin activates these receptors, these 5-HT2A receptors on the presynaptic neuron. This is the normal. These are the normal events that occur in this pathway. So you get dopamine release, it triggers a postsynaptic response, then the serotonin is activated, it hits these 5-HT2A receptors, and since these are autoreceptors, these end up helping terminate the dopamine release, okay, in these synapses. So guess what? If you have the 5-HT2A receptors blocked, then this presynaptic neuron in this nigrostriatal pathway doesn't get the doesn't get one of its turn off release activation. And so what you do get is more dopamine released. Okay, and that's hugely beneficial because it's this synapse here in the nigrostriatal pathway where we're blocking D2, we see extrapyramidal side effects. If we can push on more dopamine, okay, then we can sort of overcome the D2. Remember, our brains are in a bucket, right? The drugs just don't go to one synapse only. The drugs are on board, they're systemic. The drugs are hitting all of the brain, right? They're hitting all the synapses, right? So interestingly enough, in this synapse, you get more dopamine release because of the 5-HT2A activation, okay? And the 5-HT2A isn't in those other pathways. So that's how these have been much more beneficial drugs, because they have much lower EPS side effects because of what I just described. Now, this is all being recorded. You can go ahead and rewatch it. Have any questions, feel free to email me. All right. So a drug in this compound, or a drug in this class, would be clozapine. So one of the first atypical drugs, causes, as we described, less EPS effects. So viewed as a breakthrough drug. It does have other issues though, a slight increased risk of seizure, some sedation and weight gain as well. Also, crazy what we'll see for some of these drugs though, while they're very beneficial for the disease states, you know, we see in this drug we're seeing inhibition of this CYP2C9 and 2C19, and then induction of 1A2, 2B, and 3A. So we're seeing inhibition and induction of cytochrome P450s while on this drug. So a lot of things to consider for drug-drug interactions here. Another drug in the class is olanzapine. Again, weight gain can be a big deal. Also, the sort of increased cholesterol and triglycerides is an issue here as well. Ziprasidone, again, no weight gain here, but a clinically significant QT prolongation. So people with, you know, bad hearts or with heart conditions, not good. Aripiprazole or Abilify, that might be a commercial that you've seen. Unique mechanism of action is a D2 partial agonist, so it's a D2 partial agonist. Low extrapyramidal side effects, no QT prolongation, low sedation, so not so bad. Not associated with weight gain, so Abilify, there's a good drug there for you. But you do see some interactions with CYP2D6 and some of the cytochrome P450, so got to keep that in mind. Another drug in the class, acinafine, which is Safaris, trade name. This can be sublingual, can be used sublingual. Low weight gain and metabolic disturbances. You do get some sedation and drowsiness. Not recommended for people with severe hepatic impairment. Metabolized by CYP1A2. So that's another one. Latuda is another one. Lurasidone. Again, there's some of the newer ones, and there's more and more always coming out, I feel like. no QT prolongation, which is good. Got to administer with food. So you can see there's a lot of different drugs here in this class. So a summary of the second generation atypical antipsychotics, similar efficacy, less overall EPS side effects. Biggest consideration for forensic toxicology, again, another reason why you want to know about these drugs for forensic toxicology is look at the crazy things that it can do to all the cytochrome P450 enzymes. You have induction and inhibition of the same cytochrome P450s, right, and different. So these interactions might be a factor if there is a drug on board that, you know, is a drug that is being its inhibition is being inhibited, right, because of the antipsychotics medication on board as well. There might be a very potential damaging drug-drug interaction there that must be considered when interpreting those results, right? So these interactions, look at all these enzymes that you can see some interesting, you know, clozapine inhibits CYP2D6 and CYP2C19 and induces CYP1A and 2B and 3A, right? So if clozapine's on board and you're taking a bunch of other drugs that are associated with these, the primary substrate for these other cytochrome P450 enzymes, there can be some issues. So that's why another good reason why we want to know about these drugs. Wow, okay, that's it. So thank you so much for watching, you guys. Sorry about the pauses and stuff. Hopefully you didn't hear me yelling about the street sweeper, but I think we got that taken care of. If you guys have any questions, comments, concerns, feel free to email me. Again, if you haven't met with me one-on-one and you would still like to, if we weren't able to do it, hit me up and we can do that this week, next week. No problem there. And I've really enjoyed interacting with you in the few moments that I have been able to see you guys. Again, this is not an ideal semester at all, but again, I look forward to working with you in next semester, and hopefully I get to see you guys all next semester at some point. So thanks so much, you guys.